Hello, my name is Farid Khan. I'd just like to introduce myself and give you an overview of what type of work that I'm involved in. I work in Perfect Smile Putney. I've been working there for quite a few years now. So I've got a special interest in TMJ, which is the jaw joint, and TMJ dysfunction is also known as TMD, which is temporomandibular joint dysfunction. And it's quite a common condition. Some studies have shown that up to 2/3 of the population may have some degree of the TMD. However, most people, the symptoms are very mild and it's not really of any consequence. But I would say maybe up to 10% of the population have got symptoms that they notice from day to day, which can be clicking of the jaw, it can be some jaw ache, pain in the jaw muscles, pain in the TMJ. Sometimes you can get earaches, often you can get headaches, jaw pain, neck pain, stiff jaw, grinding, clenching, these kind of symptoms. Sometimes you get limited opening where you can't open your mouth properly. So some people have these kind of issues, and this is known as temporomandibular joint dysfunction syndrome. There's various opinions about what causes it and how it should be treated. There's differing views on it. I don't think there's a real consensus on it. So everything that I say is basically my own opinion. It's not been established in clinical trials, although I am trying to gather data so that we can publish it. But as I said, there's different opinions. Now, I've been involved in TMD treatment for the best part of 10 years, and I've always been interested in what causes it. And even when I was a student, I did an elective on temporomandibular joint dysfunction. I used to study at Leeds Dental Hospital. So in the Leeds Dental Institute, we had an oral surgery department that treated TMD patients, and I did a summer elective there. And with my consultant at the time, we published a paper on it. So ever since then, I've been interested in it. And I've done a lot of training in dentistry, in implantology, in oral surgery, and general dentistry, and so on. But in all of the studies I've done, nobody really talked about temporomandibular joint dysfunction very much, and nobody really talked about what causes it and how it should be treated. However, I did some courses a few years ago, and somebody pointed out to me that a lot of the temporomandibular joint dysfunction is to do with the position of the jaw. Now, this makes sense to me because I've always been interested in mechanics and and the mechanics of the jaw. And the muscular interactions, how the muscles control the jaw and how the joints work and how the bite functions. So I've always been interested in that. And then somebody pointed out to me when I was on one lecture one day that if the bite is wrong, then it will displace the jaw. Now, because the jaw is one bone, it starts from the TMJs and it comes down to your chin. And obviously the lower jaw is mobile, so it's moving now as I'm talking, it moves when you eat. The top jaw is fixed to your skull, it doesn't move. So at the end of the day, the lower jaw has to come in to the position dictated by the top teeth when you bring your teeth together. Now, if there's some sort of discrepancy between the size and shape of the top jaw and bottom jaw, then just from basic mechanics, it's inevitable that there's going to be some displacement of the lower jaw in order to fit into that space. Now, because this is one unit, then if the lower jaw is displaced, it's inevitable that it's going to be displaced in the joints as well, what we call the TMJs, which is your jaw joints, just in front of your ear. So if there's a displacement of a bone within a joint, then you're going to get some sort of joint dysfunction, because clearly the ball of the jaw, the ball of the joint needs to be in the correct position in the joint. So if the bone displaces, there'll be dysfunction. So that dysfunction can manifest as clicking or pain in the joint, as I said earlier, or because this is so close to the ear, if it pushes back in the ear, there's a risk of ear compression, so you might start to get an earache. So I'll give you an example. I used to suffer a lot from pain in the aeroplane when I used to fly, and my late father, he was a GP, he was a doctor, and he said to me, well, there's not much you can do about this, you just need to swallow, and by swallowing you can clear your eustachian tubes and you'll feel better. So that's what I used to do. But then later on, when I started to understand the position of the jaw, I treated myself and created more space and allowed my jaw to move forward, and then decompressed my ears. So now I don't have so much ear pain when I fly. So there's so many interactions. But anyway, going back to the basic philosophy of the treatment, traditionally The treatment for TMJ is sort of mouth guards, mouth splints that hold your jaw in a better position, or these days on the NHS they do a lot of jaw physiotherapy, which helps the muscles relax and stretch out muscles. Some people, if they get a lot of stiffness of the jaw, the standard treatment is that they have Botox injections into the jaw muscles. This is something that neurologists do a lot when people have muscle spasms. So I hear of patients who've got chronic neck pain or headaches, and neurologists inject Botox into the muscles because the Botox, it calms the muscles down. It makes them stops them clenching so hard. So then the muscles relax and the patient gets relief. So there's so many different strategies to treat it. But going back to what I'm interested in, the basic philosophy of my treatment is that the lower jaw has to fit into the bite. So therefore, if there's a discrepancy in the bite between the upper and lower jaws, the lower jaw displaces. If it displaces, it's going to have an effect on the TMJs. It's going to have effect on the associated structures, like the ears nearby. It's going to have an effect on the muscles attached to the jaw. Now, this is very interesting because there's a lot of muscles. I read somewhere that there's up to 142 muscles that are directly or indirectly attached to the lower jaw. And these start in your head, they go through your face, they go through your neck, they go to your shoulders, even back. All of these muscles are directly or indirectly attached, related to the jaw position. So for example, you have muscles at the anterior of your neck, you've got muscles on the side of the neck, muscles on the back of the neck. They're all having some effect, they're all when the jaw position. Another thing that I read is that there's studies going back 100 years which show that the jaw position has an effect on the head posture. And one of the reasons for that is that if your jaw is pushed backwards, it's partially blocking your airway. So this is going off on a tangent for a second. This can cause snoring and sleep apnea. So a lot of people who suffer from snoring is because the jaw is pushed backwards in the airway and it's partially blocking it. So therefore, you can get these things called mandibular advancement appliances, which are basically snoring appliances that you put this mouth guard in at night and it holds your jaw forward. So it makes sense that if the jaw is forward, you're going to have more clearance of your airway, you're going to breathe better. But going back to the study that I was referring to, some studies have shown that if the jaw is pushed backwards, because it's partially blocking your airway, in order to keep your airway open, in order to keep it patent, people tend to have a forward head posture because it improves the airway flow. Now, if you have a forward head posture, it's going to affect your cervical spine. It's going to put stress on that. It's going to put stress on your shoulders. Your head, naturally, the center of gravity should be going through the shoulders. But if you're holding it forward, you're going to have stress there. So again, the position of the jaw can have knock-on effects on multiple other systems. Anyway, as I said, my philosophy is, the way I work on this is that I believe that the bite has a major influence on the position of the jaw. And this is based on common sense, that when you bite your teeth together, the lower teeth have to interact with the top teeth. So if the upper and lower jaws and the teeth are in perfect alignment, your lower jaw is going to close perfectly. However, it's common that there's a discrepancy between the size and shape of your top jaw and bottom jaw. So if there's a discrepancy, when you bite together, the top jaw is going to have an influence on the position of the lower jaw. So I give an example, if the top jaw is relatively narrow and the bottom jaw is relatively wide, the lower jaw is going to have to pull back a little bit to get into the bite. So if it pulls backwards, of course it's going to displace in the joints. And then that can have a knock-on effect causing TMJ pain or clicking. Clicking is due to the fact that you've got the condyle of your jaw and you've got a disc, and if it separates off the disc, you hear a click. Okay, so the point is this, is that you get clicking, and then as I said, it's near the ear, so it can cause ear compression, all these kind of issues. So there's clearly a relationship between the position of the jaw and the bite, and this is based on basic mechanics. So even though, as I say, there's no clear studies to show exactly what causes TMJ, so there's a lot of confusion, there's a lot of debate in this field, you can still rely on basic mechanics to say, well, okay, then we can agree on the fact that if there's a discrepancy on the size and shape of the top jaw and bottom jaw, there's got to be some displacement of the lower jaw. So if there's a displacement, then that is going to have an effect on the joints and also the muscles attached to it. I don't believe that the jaw is independent of the muscles attached to it. It's common sense that if a bone displaces, then the muscles attached to it is going to have an effect on them. I'll give you an example. If I hold my arm like this, it's in a comfortable position. But if I do this, I'm going to have strain on my wrist, but also I'm going to develop tension in these muscles here, which are pulling it that way. And I'm going to have tension on these muscles there, because obviously these muscles are attached to my hand. So similarly, the muscles attached to the jaw they're going to have, if the jaw displaces, they're going to have effect on the muscles, and that can manifest as muscle tension, which may be that you get a stiff jaw, it may be that you get a headache because these muscles are attached to the jaw, you maybe get a stiff neck, you may grind your teeth, you may clench your teeth. Now there's multiple reasons for grinding and clenching, but one of the reasons can be the fact that you're building up tension in the muscles. Okay, so anyway, so if you accept that the bite can affect the position of the jaw, then if the patient's having TMJ dysfunction, then it follows that if you can study the bite and you can figure out, okay, how the bite may be influencing the position of the jaw, then if you can realign the bite some way, then you can get a better jaw position. So this is the work that I've been working on for the last 10 years or so, and I've treated, I would say even now I've got like maybe 400 patients on the go, and I've treated probably, I haven't counted them, probably the best part of 1,000 patients over the last 10 years or so using these techniques. A lot of people don't come in just for TMJ, although the majority of the patients I see now are TMJ related, but the ones I was seeing earlier, they were coming in just for the tooth straightening. And when they come in for tooth straightening, because I was thinking about this, I used to ask them, well, do you get any clicking of your jaw? Do you get any headaches? Do you get any jaw pain? And it was surprising the number of people who said, well, actually, I do get these symptoms. So then I would say, okay, then let's monitor them and straighten it. And I would, the way I developed the plan is I wouldn't just be thinking about straightening the teeth. I'd be thinking about, okay, how are these teeth, how is this alignment affecting the jaw position? And then I was thinking, okay, I can see that. So let me see if I can straighten the teeth, but also improve the jaw position. So what I found was, as I do that, and I was taking reports from my patients, the vast majority of them were saying, actually, yeah, my headaches are better. I used to get these headaches all the time. Now I don't get them so much. Or I used to get neck strain. I don't get it so much. Or I used to get a stiff jaw. I don't get it so much. Or I used to get clicking. I don't get it so much. Or my ears used to block up easily and I don't get it so much. So that was telling me that, okay, yeah, this is confirming. This was like the first 4 or 5 years when I was doing this work. The aim of the treatment to straighten the teeth, but then I would ask the patient if they've got any symptoms that I thought would be relevant. And as I said, I was surprised that maybe 80% of them said, oh, actually, I do have these symptoms. I didn't think it was related to it. The symptoms could be as simple as grinding the teeth, okay, which indicates to me that there's muscular tension in the jaw. Now, so therefore, these kind of symptoms, and as I was treating them, the vast majority of them were saying, actually, it's improving. So that then led me to then study it more and more. So now basically, so what I do now basically most of my practice is based on TMJ. I've been more focused on it in the last 5 years or so, and seeing mainly TMJ patients, seeing a wide variety of them. And obviously there's different levels of TMJ, there's different levels of TMD, and there's so many factors. One of the factors is your age. If you're young, I found that the patients tend to respond really well. And young, I mean in the 20s or 30s. And then I see that when they're in the 40s, maybe not so well, maybe the 50s, not so good, 60s is difficult. But that's the same in anything in medicine. As you get older, your body doesn't heal as well as it used to. And as you get older, you get more wear and tear. So it makes sense that if your jaw's being displaced, you're getting minor stress in the joint, and then that builds up over 20 years, you're going to have more damage in the joint than if you'd only had it, you're still young and it hasn't had time to damage. Okay, so there's various different things, various different results that we see, but as a general rule, what I found is that in the vast majority of cases, I'd say maybe about 90% of cases under the age of 45 and maybe 80% over the age of 45, I've seen that they've reported significant improvement in the TMJ symptoms. Some of them said that it's more or less resolved. Other people have said that it's better than it was. Most patients, not every patient, and it may be because there's other factors involved. That's not just the bite, and it may be because they're just not responding well to the treatment. It happens, but the fact is that in a lot of patients, the bite is influencing the position of the jaw, and then that can have an influence on the TMJ. So that's what I focus on. So if you think you've got TMJ issues, now the issues can be variable, and they can be from other factors as well, which may or may not be related to TMJ. So you always need to see your primary care specialist first, like your general GP, your doctor. And then if the doctor is not sure, they will refer you to another specialist. For example, suppose you get headaches, go and see your doctor. The doctor will investigate. If the doctor can deal with it, that's fine. If they're not sure, they'll refer you to a neurologist. Similarly, if you're getting ear congestion or earaches, see the doctor, then usually will refer you to ENT. Okay, so because they need to do the correct investigations, the specialist. And the kind of patients that I see have already usually seen a specialist, a neurologist, who've said, I can't really see what's causing your headaches, or they've seen an ENT doctor who says, I think your ears are okay, but they're still getting the ear pain, or they're still getting the headaches, and then they do their own research. They think, oh, maybe a TMJ might be causing it, so they come and see me, and then I take the history, but I also examine the TMJs. If the TMJs are really tender when you press them, if the muscles around the jaw are sore when you press them, this indicates that there's stress in the system. And if there's stress in the system, that indicates that they probably do have some TMJ symptoms, which may or may not be causing the other symptoms that they're talking about. So then once I've seen that, then obviously I'm going to examine the bite. And these days, we have modern technology which makes life very easy. We have 3D scanners where I can scan the teeth. If I scan the teeth, I can see on a virtual model the bite, and the software will also give you a bite report, which tells you exactly what's the level of interaction of each tooth against the other. So you can see where there's a heavy bite and where there's a lighter bite, and then you can sort of correlate that to what you think is the ideal based on normal dental studies, and say, okay, how's this deviating? And then using software, you can then correct that, and then you can make patient appliances that will then realign the bite and then monitor them, and that's the sort of treatment that I do. And as I said, I see that a lot of patients get better. So if you think that you may have TMD, or you know somebody who might, and the symptoms of TMD can be varied. As I said, you might get headaches, you might get jaw pain, you might get TMJ, you might get pain around the joints, you might get clicking, you might get locking where your jaw gets stuck, or you might get the earaches a lot, you might get neck pain. All of these symptoms may or may not be related to TMJ. But if you think that you may have it, and obviously you've seen the specialists, if it's something not directly related to your jaw, and you still can't quite get to the bottom of it, then it's worth having a chat to see whether this is causing it. And if you want to arrange a chat, then I offer, because I'm very interested, I'm interested in seeing more patients and getting more data, because I think that it's exciting, the fact that we have modern technologies, and modern technologies give us a lot more information and give us a lot more opportunity to treat it, and treat it in a patient-friendly manner, where most patients find these appliances very comfortable to wear. So I think there's a lot of opportunity for the future. So I'm interested in seeing more patients and learning more, and then hopefully teaching and so on. So if you think you may have these issues, I offer free consultations. Often we do them online first. You don't even have to come here. We can do it online, have a chat to see what your symptoms are. Usually I find that on Zoom calls these days, I can actually see the bite quite well. I can see the jaw movement, so I can discuss it with the patient. And then if we think that they may have TMD, then they come to London. We have a check, examine the jaw in detail, take a scan of the teeth, and then examine it in more detail. So my details are on the website, so if you're interested, if you think you may have it, or you know somebody who may have it, then send an inquiry down. And as I said, I'm happy to do a free online consultation. We can and then we can discuss it, and you get more information. It's good for you, good for me. So hopefully if you've got that, then I look forward to speaking to you soon. Thanks a lot. Bye.